Welcome back to the deep dive. There is a specific kind of anxiety that comes with looking at the skin.
Hmm.
Whether you are a medical student, a resident, or even a seasoned pro in another specialty, the skin can be, well, it can be intimidating.
It is.
It's the largest organ in the body. It's right there on the surface staring at you, and yet it is incredibly difficult to interpret.
It is deceptive. That's the word I always use. You look at a red patch and your brain just says, oh, it's a rash.
Right, just a rash.
But the sheer volume of information you need to retain to differentiate between something totally benign, like a mild allergic reaction, and a cutaneous manifestation of a serious systemic disease like lupus or clotting disorder is staggering. The stakes are hidden in plain sight.
Exactly. And the problem is, when a patient is sitting right in front of you, you don't have time to go dig through a massive library or read a dense chapter. You need answers, and you need them now.
You get fast.
So today we are doing a deep dive into a resource designed exactly for that pressure cooker environment. We are looking at Ferri's Fast Facts in Dermatology.
A classic reference, and a necessary one, I think.
Just to set the stage for everyone, the primary author here is Dr. Fred F. Ferri. He's a clinical professor at the Alpert Medical School at Brown University.
Right.
And for this text, he worked with associate editors Dr. James Studiford and Dr. Amber Tully from Jefferson Medical College. So we are dealing with some heavy hitters in clinical education here. I mean, these are people who teach doctors how to be doctors.
Absolutely. Dr. Ferri is a name that's, synonymous with concise, high-yield medical information. And that's really the mission to this specific deep dive. We aren't trying to read a 1,000-page textbook today.
No.
We are exploring how this specific book functions as a tool. It's not about memorizing every sentence. It's about understanding how to use it to solve problems.
I love the phrase used in the preface to describe this mission. Dr. Ferri calls this book a portable, visual, peripheral brain.
That is the perfect description.
Yeah.
In modern medicine, the volume of knowledge is doubling at an insane rate. You cannot possibly memorize everything.
No way.
You need a peripheral brain, something external that you can access immediately to ensure safety and accuracy. This text is designed for medical students, residents, allied health professionals, and practicing physicians who need that rapid diagnosis and treatment data. It's about cognitive offloading.
So let's unpack this peripheral brain concept. How does the book actually organize this chaos? Because if I'm in a hurry, I can't be reading long, flowery paragraphs. I need the data.
Right. And that is why Ferri uses a very strict, standardized approach. In the preface, he outlines that every single disorder in the book, and there are over 160 of them, follows the exact same 5-part structure.
Which is huge for cognitive load. You know exactly where to look on the page every time.
Precisely. Let's break down those 5 parts because they mirror the way a clinician should think. It starts with general comments.
Okay.
This gives you the definition and etiology, basically what is this thing and what causes it.
So step 1, define the enemy.
Correct. Step 2 is keys to diagnosis. This covers the clinical manifestations, what the patient complains of, and the physical exam findings, what you see. It also lists necessary diagnostic tests.
Like, do you need a biopsy, a blood test, that kind of thing?
Exactly. Do you need a scraping? Then step 3 is crucial. Differential diagnosis.
What else could this be?
What else could this be? This is the safety net. Step 4 is treatment, which is obviously what the patient cares about. And finally, step 5, which I think is the most valuable part for a learner, clinical pearls.
I love a good clinical pearl. That's usually the wisdom that comes from experience, right? The stuff that's not in the textbook.
Exactly. It's the nuance. A pearl might be something like, don't use this medication on the face because it causes thinning of the skin, or this rash often appears before the fever. It's the kind of tip that prevents medical errors. So that standardized format means you can scan a page in seconds.
Okay, let's get into the actual content. The book is divided into 3 main sections. Section 1 is evaluation of skin disorders. It seems like this is the foundation before you even get to the specific diseases.
You have to start with the process. You can't diagnose if you don't know how to look.
Yeah.
So chapter 1 breaks down the history and physical examination. But what I find really practical here, and this is something Ferri is known for, is that it organizes dermatosis.
Which is just the medical term for skin diseases.
Right, skin diseases. It organizes them by region.
By region, you mean? Like by body part?
Yes. Think about the workflow. A patient doesn't walk in and say, I have psoriasis. They walk in and say, I have this weird patch on my elbow.
Ah.
You aren't examining a disease, you are examining a person. So the book lists conditions by location. Scalp, face, oral mucosa, that's the mouth, axilla, or armpit, hands and feet, genitalia, and inguinal areas.
That makes so much sense. If I see something on the foot, I don't want to waste time reading about scalp conditions.
Exactly. And it gets even more specific. It has a category for photo-distributed areas.
Meaning areas hit by the sun.
Yep. If a rash is only on the face, the V of the neck, and the forearms places where the sun hits, that is a massive diagnostic clue. It immediately narrows your list of suspects to things like, I don't know, drug-induced photosensitivity or lupus. Organizing the data this way matches the mental workflow.
There's also a subsection here on dermatosis in the young. I imagine pediatrics is a whole different ballgame when it comes to skin.
It is, and the stakes can be very high. Babies have different skin physiology. So the text highlights specific groups like newborn infants with vesicopustules.
Vesicopustules, that's a mouthful.
It just means blisters filled with fluid or pus. In a teenager, a pus-filled bump is usually acne. In a newborn, it could be a simple heat rash, or it could be herpes simplex or a staph infection. The implications are totally different.
Wow. And I see one entry in this section that looks particularly urgent. Febrile children with rash.
That is a critical category. This is the nightmare scenario we talked about. A child with a fever and a rash can be anything from a mild viral illness like roseola to a life-threatening bacterial infection like meningococemia, which can kill in hours.
Gosh.
So having a quick reference to differentiate those based on the look and spread of the rash is vital. It's not just convenient, it's a safety mechanism.
So that's section 1, how to evaluate. Now, section 2 is titled differential diagnosis. How is this different from the first section?
This is where the detective work really happens. In section 1, you're looking at a location. In section 2, you're looking at a symptom or a presentation, and the book helps you build a list of suspects. It forces you to pause before you jump to a conclusion.
Okay, can you give me an example from the outline of how this works?
Sure. Let's look at hair issues.
Yeah.
A patient comes in with hair loss, which we call alopecia. The book doesn't just list hair loss. It breaks it down into alopecia non-scarring and alopecia scarring.
That distinction sounds technical, but why is it so important for the patient?
It's fundamental. Scarring alopecia implies permanent destruction of the hair follicle. The hair will never grow back.
Oh.
Non-scarring might be reversible, maybe it's stress, maybe it's hormonal. If you treat scarring alopecia as if it were non-scarring, you waste time, and the patient loses hair permanently. The differential diagnosis section forces you to categorize it before you start treatment.
That's a powerful example. I also see it lists sensory issues. Pruritus, which I've learned means itching.
Pruritus is one of the most common complaints in dermatology, and here's the kicker. Sometimes there is no rash to see. The patient is just itching. So the book lists causes for that, and also lists pruritus ani, which is localized itching. This helps you figure out if the itch is a skin problem or a symptom of something else, like liver disease.
And then you have the systemic indicators. We talked about the febrile child, but there's also an entry for arthritis, fever, and rash.
That is a classic triad. When you see joint pain, fever, and skin issues together, you have to stop thinking about skin cream and start thinking about systemic diseases, things that affect the whole body.
Like what?
Things like gonococemia, Lyme disease, or rheumatoid conditions. The book lists cutaneous manifestations of internal disease in the appendices, but this differential section helps you connect the dots in real time. It also covers, specific physiological failures like anhidrosis, the inability to sweat, or flushing.
So this section essentially stops you from getting tunnel vision.
That's the goal. It promotes critical thinking. It forces the learner to compare and contrast possibilities. You aren't just matching a picture, you are following a logical path.
All right, moving on to the main event, section 3, diseases and disorders.
This is the encyclopedia. Chapter 3 covers 164 specific conditions arranged alphabetically from A to Z. This is where you go when you have a specific diagnosis in mind. You just need the facts.
Looking at the table of contents, the range is incredible. It goes from the things we all know, like acne vulgaris and atopic dermatitis, which is eczema, to some really specific, intense stuff.
It really runs the gamut. You have your common infections like herpes zoster, that's shingles or impetigo, which is that crusty bacterial infection kids get. Then you have sexually transmitted infections like syphilis, which has a huge variety of skin manifestations.
And then the scary stuff, melanoma, Kaposi sarcoma,
systemic lupus erythematosus, and pemphigus vulgaris. These are serious, complex conditions. Pemphigus, for example, is an autoimmune blistering disease that can be fatal if not treated. But then, if you look at the index, you also see unique, almost odd conditions like hairy tongue.
Hairy tongue. Please tell me that isn't literal.
It is surprisingly literal. It's an overgrowth of the papillae on the tongue that makes it look hairy.
No.
Yeah. It's usually benign, often caused by smoking or poor hygiene, but it looks terrifying to the patient. Or amalgam tattoo, which is a benign blue or black mark in the mouth caused by particles from silver dental fillings.
So the book covers the things that kill you and the things that just freak you out.
Exactly. And distinguishing between the two is the whole point.
Let's try to apply that standardized format we talked about earlier to one of these. Let's pick something common, like acne. Everyone thinks they know acne.
Acne is a perfect example because it shows why medical precision matters. So you'd flip to the acne vulgaris section. First, you'd read the general comments. This would explain that it's a disorder of the pilosebaceous unit, the hair follicle, and oil gland.
Then, keys to diagnosis.
Right. What does it look like? The text will list comedones, that's blackheads and whiteheads, papules and pustules. It details the physical exam findings so you can confirm, yes, this is acne, not something else.
Then, differential diagnosis. What looks like acne but isn't.
Maybe rosacea, maybe folliculitis, maybe acne keloidalis, which isn't regular acne at all.
I saw that in the index, acne keloidalis.
That's a scarring condition usually found on the back of the neck.
Hmm.
If you treat that like regular teenage acne, it won't work, and the patient will develop permanent scars. That scientific clarity found in the text is vital. The book uses precise terminology, distinguishing nodulocystic acne from acne vulgaris, because precise terminology leads to precise treatment.
Speaking of treatment, the index lists things like adapalene and benzoyl peroxide gel with page numbers referencing the acne section.
Exactly. The treatment section gives you the pharmacological tools. It tells you what to prescribe. And finally, the clinical pearls for acne. This might be a tip about how to avoid skin irritation or how long to tell the patient to wait before they see results.
Okay, we've covered the diseases, but there is a section at the back, the appendices, that seems like the toolkit for the practitioner. Usually appendices are where boring data goes to die, but these seem practical.
Do not overlook the appendices. In a Fast Facts book, the appendices are often the most used pages. Appendix 1 is topical steroids.
Why is that its own appendix?
Because topical steroids are the bread and butter of dermatology, but they come in a huge range of potencies. They're classified from class 1, super potent, to class 7, very weak. You need to know which class to use on thick skin, like the hand, versus thin skin, like the face or groin.
What happens if you get it wrong?
If you put a class 1 super potent steroid on the face, you can cause skin atrophy, literally thinning of the skin and permanent stretch marks. Having that chart handy is a safety requirement. It ensures you match the drug to the body part.
That makes sense. And Appendix 2 is cutaneous manifestations of internal disease.
This connects back to what we said about the skin being a window. This appendix lists signs like acanthosis nigricans, which is a velvety darkening of the skin, often on the neck, and links them to internal issues like insulin resistance or malignancy. It's a cheat sheet for systemic health.
There's also Appendix 3 for nail diseases and Appendix 4 for stings and bites.
Stings and bites is a great rapid reference, especially if you work in an emergency room or primary care. Spider bites, tick bites. You need to identify the reaction pattern quickly to know if you need antivenom or antibiotics.
One thing we haven't touched on enough is the visual aspect. The preface mentions this is a visual brain, we can't see it on a podcast, but how important is that?
It is non-negotiable. Dermatology is a visual specialty. You can read a description of a rash, but you need to see it. The book credits the Jefferson Clinical Images Collection and other color atlases. The text relies on these images to aid in rapid pattern recognition. The image confirms what the text describes.
Okay, we've toured the book, we understand the structure. Now I want to put you on the spot. We like to do a little review exercise for our listeners to see if they've really grasped the peripheral brain workflow.
I'm ready. Let's do a simulation.
Here is the scenario. You are a resident, it's late on a Friday, a parent brings in a 5-year-old child, the child has a high fever and a rash that involves the palms of the hands. You have Ferri's Fast Facts in your pocket. What is your order of operations?
Okay, good scenario. High stakes. Here is how I would use the book. Step 1. I go to Chapter 1, Evaluation. I need to perform a proper history and physical examination. I need to characterize the rash. Is it flat? Is it raised? And specifically, I confirm the distribution. You said palms of the hands. That is a specific region.
Okay, you've looked at the patient. Now what?
Step 2. I flip to Chapter 2, Differential Diagnosis. I am specifically looking for the entry febrile children with rash, or looking up causes of rash on palms and soles. This gives me my list of suspects. Is it hand, foot, mouth disease? Is it scarlet fever? Or is it something dangerous like Rocky Mountain spotted fever?
You've narrowed it down. Let's say, based on the season and the look, you suspect Rocky Mountain spotted fever.
That leads to step 3. I go to Chapter 3, Diseases and Disorders. I look up the specific entry for Rocky Mountain spotted fever. I check the keys to diagnosis to confirm my suspicion to guess what I'm seeing. Then immediately I look at the treatment section, see the antibiotic dosage, likely doxycycline, and I read the clinical pearls to see if there are any specific warnings for treating a child.
Boom! That is a clear, logical workflow. You aren't guessing, you're following the map.
And that is exactly what this book is designed to provide. A map in a chaotic clinical landscape. It turns panic into a plan.
We are coming to the end of our deep dive into Ferri's Fast Facts in Dermatology. It really does seem like the perfect bridge between those deep, dusty textbooks and the immediate needs of a patient.
It is. But I want to leave the listener with one final thought, something found right in the front matter of the book in the notice.
A disclaimer.
It's more than a disclaimer, it's a philosophy. It says, knowledge and best practice in this field are constantly changing.
Meaning what?
Meaning that medicine is not static. New research comes out, new treatments are approved, and old treatments are found to have new side effects. This book is a foundation. It is a peripheral brain, but it cannot replace your actual brain. The practitioner must always rely on their own experience and prioritize safety.
That's a great reminder. The book gives you the data, but you provide the judgment. Well, to all our listeners, whether you are a student trying to survive your rotations, a pro looking for a refresher, or just someone fascinated by the complexity of the human body, we hope this helps you understand how medical professionals organize their thinking. Keep that peripheral brain handy, but keep your critical thinking sharper. Thanks for listening to The Deep Dive.